Hi guys, this is Dr. Mahendran J, your Forensic Medicine and Toxicology faculty from Marrow. Good to see you again. Here we are for the discussion of recall questions of Forensic Medicine and Toxicology subject from INI-CET May 2023 session. Okay, so this is the analysis. So we have gotten around 11 questions from the subject Forensic Medicine and Toxicology. You can see the topics. Toxicology played a very big role. You can see that we have gotten around 6 questions from toxicology itself. Cocaine poisoning, morphine poisoning, alcohol, metals, scorpion and snakebite management. These are the routine topics that is for INI-CET, but still, if you see alcohol, normally we get questions on alcohol, maybe from the methanol poisoning management or from alcohol withdrawal symptoms management. But this time we've gotten very specific question on the issue of drunkenness certificate, right? So that is one important medical legal exercise which every registered medical practitioner has to know. Okay, issue of drunkenness certificate. That is again very important. Another one is scorpion sting management. We can say that is near new topic because last year we in one session we got a question on scorpion sting management. Again, we got on the same topic question. You see, thanatology, it's about postmortem changes. Asphyxial death, it's about drowning. Sexual offense, as always, it is medical examination of rape survivor. Ballistics, from the traumatology, we have got questions on firearm injuries and from the thermal injuries as well. So normally when we talk about traumatology in INI-CET sessions, we get questions from mechanical injuries and firearm injuries. This time we got questions from thermal injuries and firearm injuries. Okay, so this is the analysis, and I'm happy that we've gotten around 11 questions from forensic medicine. Usually we get around 7 to 8 questions in INI-CET sessions. This time we have got better contribution from the subject. I'm also happy to know that most of the students have done well in forensic medicine questions and they've got a better strike rate. Okay, so let's start with the question as such. And as you all know, this is a recall session. The questions are from the memory-based recall from the students. So there may be some little variations on the actual phrasing of the verse. Doesn't matter. What we're going to learn is about the concepts. Okay, so let's learn about the concepts of these particular areas. Which of the following is not true about the postmortem changes? Okay, so this is from the topic thanatology. Greenish discoloration, the right iliac fossa is the earliest sign of decomposition. Yes, that is true, right? In drowning, the postmortem hypostasis seen in the lower limbs. That is not right. So we'll be seeing why it is not right. Adipose hair is seen in bodies recovered from the water source. Yes, because adipose hair we need warm, moist climate, right? We need moisture. So water source is essential. That is true statement. Cadaveric spasm is seen only in the specific group of muscles. Yes, that is true, right? So we'll be seeing each and everything. You see, this is the classification of postmortem changes. So to have a better understanding of the postmortem changes, first we have to start with the basics. The basics is the classification. You can classify the postmortem changes chronologically into immediate, early and late. You can see immediate changes, loss of voluntary movement, irreversible stoppage of circulation, irreversible stoppage of respiration. Okay. Early changes, we can see some changes in the eye. You can say that is tachynoir, and you can also see one of the important changes in the retina, that is Kevokian sign. Fine. Segmentation of retinal vessel. These are the two important eye changes. And we have postmortem cooling, that is called algo mortis. We have got postmortem staining, that is called livor mortis. We have got postmortem rigidity of the muscle, that is called rigor mortis. So we have got three mortis: algol, liver and rigor. And late changes is basically we have got decomposition. The body will be decomposed, body will be destroyed, disintegrated. If it is done by our own enzymes, you call it as autolysis, lysosomal enzymes. If it is done by bacterial enzymes, that process is called as putrefaction, right? The entire sequence, the entire process of postmortem resorption, that is called taphonomy. We have discussed in our main videos. Now you see putrefaction, I told you that is because of bacteria. You have a lot of bacteria involved in this. The most important bacteria is your Clostridium welchii. And the most important enzyme, that is called lecithinase, which is very, very important for this is one important lytic enzyme which is responsible for the dissolution of the tissues. Okay, and Clostridium welchii is also called as a chief destructive agent in putrefaction. We all know that. So the first important change, that is cadaveric spasm, what you can see is the presence of grass tightly clenched in the hand. You remember that it is specific, it's a spasm of specific group of voluntary muscle. Remember, it is seen only in the voluntary muscle. That we have to know. When we talk about rigor mortis, it is a spasm of, it is a rigidity of both voluntary muscle and involuntary muscle. But cadaveric spasm is seen only in the voluntary muscle. And also do remember, rigor mortis is a post-mortem phenomenon. This one is an ante-mortem phenomenon. That is very important. Right? This is an ante-mortem phenomenon. That is why presence of grass tightly clenched in the hands of the drowning victim, we say that that is very important sign to say that this person was alive at the time of drowning. Okay, so this is one important ante-mortem phenomenon. And you can also see that here what we see is there is no primer relaxation phase. Normally the muscles will be having primer relaxation phase after death, but in this phenomenon there is absence of primer relaxation. That is another important point that we have to know with regard to cadaveric spasm. Now this is the decomposition chain, the color change, where you can see the greenish tinge in the abdomen. But where it starts externally, the first site where it starts externally is the right iliac fossa. Right? You can also say that is the first external sign of putrefaction, the color change in the right iliac fossa. This is important because it will tell you the idea about the time since death, because in summer it takes around 12 to 18 hours. In winter it takes about 1 to 2 days. Fine. So this is the earliest external sign of putrefaction. Simultaneously, if they ask you what is the first site of color change in decomposition, right, overall you can say that is iota. Right, here externally it is the right iliac fossa that is showing the earliest sign of decomposition. Remember, it will help us to determine the time. The second important putrefactive change is the gas production. You can see the body is completely bloated in this because of the accumulation of the gas. You have a lot of gases produced during decomposition. One of the most important gas is hydrogen sulfide. That is, again, this hydrogen sulfide is reason for the greenish tinge in the decomposition. Fine. So you can see this is hydrogen sulfide, the most important gas. And because of excessive accumulation of the gas, as you can see, the body is completely distended and you can see bloated body. And there is one more important feature that we have to know with regard to the gas formation, that is the formation of skin blisters. When we see the blister on the skin, we have to know whether it is an ante-mortem blister. Ante-mortem blister meaning that it is a burns blister. Post-mortem blister, what we talk about now, it is putrefaction, due to putrefaction. Remember, ante-mortem blister, you can see the contents. Ante-mortem blister will be having inflammatory fluid, whereas the inflammatory fluid in the sense that it will be having rich in protein and chloride, whereas a post-mortem blister, the content would be only the gas, air bubble. Fine. And when you look at the base of the blister, the base of the ante-mortem blister will be reddish or hyperemic. You can see erythemic, it is reddish, whereas the post-mortem blister, the base will be completely pale. Right? And of course, the ante-mortem blister will be showing red line, whereas that will not be present with post-mortem blister. But these are the two important ways by which we can differentiate ante-mortem blister and post-mortem blister. This differentiation is again important because we have got another question based on the same thing. Right? So you can see this is the blister, post-mortem blister. This is a modified form of putrefaction, which is nothing but adipose here. As I told you, you need moist, warm climate. Whenever we have moist and warm climate, that will produce what is called as hydrolysis and hydrogenation of fat. I repeat, we have got hydrolysis and hydrogenation of fat into fatty acids, right? And that produces adipose here. Remember this one, hydrolysis and hydrogenation of fat. What kind of climate is needed? Warm and moist climate is needed. Right? And sometimes this you can see the smell will be ammoniacal smell. This is one important modified form of putrefaction. The body will be preserved as such. The second method of modified form of putrefaction is this, that is the process is mummification. And you all know that the climate which is needed for this, what is the climate that is needed for mummification? Yes, that is your dry and hot climate. Do remember guys, it is dry and hot climate. And this dry and hot climate produces drying and dehydration of the tissues. Remember, when we talk about adipose here, it is hydrolysis and hydrogenation of fat. But here it is drying and dehydration of the tissues, because of which the body will be preserved as such. And here you can see the smell is completely odorless, which is again one of your repeat PYQ, right? Repeat question. Fine. So this is mummification. And let's talk about hypostasis. And one common question that normally we get in INI-CET with regard to hypostasis, the synonym. They used to ask questions about synonym. What are the different synonyms of hypostasis? You call it as liver mortis, you call it as postmortem hypostasis, you call it as postmortem lividity, you call it as suggulation. Again, this suggulation term was asked twice in your examination, right? INI-CET session. So these are the synonyms that we have to keep in mind. Remember, normally hypostasis means, remember, it is seen in the dependent parts of the body. So if the body is kept in this kind of supine position, what is the dependent part? You can see the hypostasis in the dependent part, like back of the head, back of chest and abdomen, back of legs, right? Apart from the pressure points. Suppose if the body is kept in a prone position like this, again, what is the dependent part? These are the dependent parts: the face, the front of chest, front of abdomen, front of legs, right? So hypostasis will also be seen in the same areas. What if the body is kept in a vertical position like this? If the body is kept in a vertical position like this, in this situation, the dependent part is the lower part of the lower limbs and lower part of the upper limbs, right? If the victim is a male body, you can as well find out in the penis as well. So these are the dependent part, and this, you know, the type of hypostasis. This is called Gloven-Stocking hypostasis. When do you normally see Gloven-Stocking hypostasis, guys? Remember, Gloven-Stocking hypostasis is seen whenever the body is kept in a vertical position. And one common example that you all know is hanging case. Fine. So when the body is kept in a supine position, you can see in the back of the body. When the body is kept in a prone position, you can see in the front of the body. When the body is kept in a vertical position, you can see in the Gloven-Stocking distribution. What if the moment the body position is kept on changing continuously? When the body position is kept on changing continuously, particularly if the body in a fast flowing river or fast flowing water source, what happens is the body position keeps on changing, you will not find hypostasis at all, right? So that is why normally when the drowning happens in a fast flowing river, right, you will not find hypostasis. Again, this is not, I'm not talking about still water like lake, pond and all. It is about fast flowing river. Fine. So you can see that one important point that you have to understand is the pattern of hypostasis does not depend on the cause of death. It depends on only one thing, that is your position of the body. The distribution of hypostasis depends on the position of the body. That is the main concept that you have to understand. Maybe the color of hypostasis depends on the cause of death. Maybe what different kinds of poisoning produces variations in the color. But the pattern, the distribution depends on the position and position only. Fine. Now let us see drowning victim. You can see this is the actual position of drowning victim. You can see the dependent parts. So in the case of drowning victim, normally where will you see hypostasis? You can see in the front of face, front of upper part of the chest, and sometimes in the feet and the upper lip. This is where you can see the hypostasis, right? You imagine, you have to recollect the position of the dead body in a case of drowning, right? When you remember that, you can easily find out which is the dependent part and where you will get hypostasis. In the question, the option was given as hypostasis seen only in the lower limbs. That is not wrong. So that will be the false statement. Everything else will be the correct statement. Moving on to the next question, black food disease. This is a question on toxicology, that is metallic poison. Normally we get questions on metallic poisons in INI-CET sessions, maybe on lead, maybe on mercury and arsenic. Routinely what happens is the metallic questions on metallic poisons will be like usually on either it will be on the mercury or it will be on lead or it will be on the arsenic. So we have to know in and out about these particular metals. So in this session, we got a question on arsenic. You can see that black food disease is an endemic peripheral vascular disease seen in the toxicity of which of the following disease. Remember, in which metal that it is normally associated. This is a very, very easy question, level 1 difficulty, that is due to arsenic. Okay, so this is again one repeat question from INI-CET itself. Fine. What are the other features that you will see in chronic arsenic poisoning? Remember, chronic arsenic poisoning is also called as arsenicosis. Arsenicosis. And if this chronic arsenic poisoning is due to drinking contaminated water, then it is called as hydroarsenism. Let us talk about what are the other features that we get in chronic arsenic poisoning. You can see skin manifestation. Remember, usually the skin manifestation will be the early features of chronic arsenic poisoning. To start with, you can see that is raindrop pigmentation, that is dark brown pigmentation. You can as well see the excessive keratosis, hyperkeratosis, particularly seen in the palms and soles. You can see that in the palms and soles, bilateral palmoplantar hyperkeratosis, that is highly typical for arsenic. And this bilateral palmoplantar hyperkeratosis again may be carcinogenic. Remember, this one, arsenic is carcinogenic. You can have increased incidence of multiple cancers, right? Particularly skin cancer, you can get basal cell carcinoma, squamous cell carcinoma. All these carcinomas are more frequently seen in this chronic arsenic poisoning. Look at the nail. In the nail, you can see transverse white line, that is called Aldrich-Mees line. Remember, this Aldrich-Mees line is seen with arsenic poisoning. Yes, that is true. But Aldrich-Mees line is seen only in arsenic poisoning. That is wrong. Our Aldrich-Mees line is not seen only with arsenic poisoning. This Mees line can also be seen with thallium poisoning as well. Remember, this is again very important. This Aldrich-Mees line is not a specific finding. This is also seen with other conditions like thallium poisoning. Okay, remember that is again important, which was again asked one of your NEET exams. Fine. Neuropathy. You will find sensory motor polyneuropathy, and this chronic arsenic poisoning, it resembles Guillain-Barré syndrome as well, right? So sensory motor polyneuropathy. Peripheral ischemia is very, very common. Because of chronic peripheral ischemia, you will get peripheral gangrene as well, right? Peripheral gangrene. And if it is endemic peripheral gangrene due to that ischemic vasospasm, then you call it as Blackfoot disease. We just saw it now. It causes bone marrow depression and is also causes alopecia. So all the features, the arsenic is something which doesn't spare any system. Each and every system is affected by arsenic, right? And one older test by which we used to find out this arsenic is Marsh test, and another test, old test, that is called Range test. Nowadays we don't use this. These are obsolete tests, but still just know the name, the Marsh test and Range test, right? So you can see the pigmentation. You can also see the transverse white lines in the nails. Fine. Let's have a quick revision on the chronic lead poisoning as well. That's called plumbism. You know, it's otherwise called as Saturnism. You have got a long list of manifestations. Let's have it arranged alphabet wise. A for anemia. Remember, it interrupts with the hemoglobin synthesis. When it is interrupting the heme synthesis, obviously we get microcytic hypochromic anemia. You just have to know the name of the two enzymes which are primarily inhibited by lead. One is ALA dehydratase, and do also remember ferrochelatase. These are the two enzymes. See, multiple enzymes are at multiple level in heme synthesis is blocked by lead. But here two enzymes are primarily blocked by this lead, that is ALA dehydratase. Another one is ferrochelatase. Then we've got B, basophilic stippling of RBCs. We have got bluish, right, gums, bluish deposits in the gums, that is Burtonian line. And we have got metaphyseal dense opacities, that is called bone line, otherwise called as lead line. And we have got colics, and this is very commonly seen with painter, that's why it's called painter's colic. It is otherwise called as saturnine colic, because you know plumbism is also called as saturnism, and that is why this is called saturnine colic. The person will be having constipation. You just call it as dry belly ache. Person will have motor nerve involvement, wrist drop will be there, foot drop will be there. E for encephalopathy, which is commonly seen with organic form of lead, that is called tetraethyl lead. Organic lead, that is tetraethyl lead. CNS manifestations very, very common. Children are primarily affected, and these changes will be irreversible. Permanent degeneration will happen. The person will be having memory disturbances, learning disorders, disabilities, irritability. So everything will be seen with lead encephalopathy. F for facial pallor and G for gout. It's otherwise called as saturnine gout. How do you treat lead poisoning? We can either give EDTA, chelate with EDTA, but if the person is suffering from severe lead poisoning or lead encephalopathy, in that situation what you can do is you can give EDTA combined with either BAL, or you can give DMSA, right? So you need to add one more chelating agent which can easily cross the blood-brain barrier. Okay, so EDTA, BAL, otherwise BAL is not available, we can give DMSA. Fine, you can see the basophilic stippling. You can see the Bertonian line. Now moving on to another question. This question is on the drowning as such. The female was brought for autopsy with alleged history of being found in a lake. All of the following are suggestive of antemortem drowning, except. Okay, so this is again the question from the same topic of drowning. Regularly we get questions every session that you get questions on drowning particularly, but normally we get questions on drowning depending on the pathophysiology, based on pathophysiology of drowning, freshwater drowning, saltwater drowning, something like that. But now this session we got a question on the postmortem findings. How will you know that the person was alive at the time of drowning, right? How will you know it was a case of antemortem drowning? Fine. We have got four options. Water in the stomach. Yes, it is suggestive of antemortem drowning. White lathery froth or foam around the mouth and nostrils, again that is suggestive of antemortem drowning. Positive diatom test, again that is suggestive of antemortem drowning. Wash a woman's hand in the feet, that is a non-specific sign. It is present with antemortem drowning. It is also seen with postmortem drowning, that is basically non-specific, because this wash a woman's hand, it is not a sign of drowning, it is a sign of immersion, right? So if you look at the mechanism of wash a woman's hand, right, it is due to imbibition of water into the skin layers. The water enters into the skin layer, which is producing typical findings on the palmar skin. That is called wash a woman's hand. And if it is seen in the feet, that is called wash a woman's feet. Remember, that is non-specific. So that is the best option we've got. Let us look at the findings of antemortem drowning. Let's see externally. Externally, if you look at the hypostasis, as I told you earlier, if it is a stagnant water like a lake or pond or something, you can see that it's in the face, upper part of the chest, lower arms and the feet. Remember, if it is in the river, fast flowing river, the body keeps on moving, right? The water keeps on flowing, the body keeps on moving. You will not have hypostasis at all. This we have discussed just. Wash a woman's hand. The skin of the palm will be wrinkled. It will be bleached. It will be sodden. It will be sodden. You can even see peeling of the skin. As I told you, all these findings are suggestive of wash a woman's hand. And remember, this is not a sign of drowning. This is a sign of immersion, right? With that, we'll be able to find out the time since immersion, right? Normally, we used to say time since death, right? But here we'll be able to find out the time since immersion depending on the extent of this changes in the palm, right? Whether it is seen only in the finger pulp, or whether it is seen in the entire palm, does it include the dorsum as well? So all these things will help us to find out time since immersion. Then we have got cutis anserina, goosebumps, and you all know that it is again a non-specific finding. Froth in the nostril, that is suggestive of antemortem specific finding, antemortem drowning, right? Particularly, the typical character of froth is it is mucoid, it is tenacious, persistent froth, and it is so fine. This is the typical appearance of the drowning froth. And remember, one important point that you have to keep in mind is the presence of froth in the nostrils. It tells you it is suggestive of antemortem drowning, but it is not a classical sign. You can't say that it is confirmatory sign of drowning, because remember, the froth will not be there if it is a case of dry drowning or if it is a case of hydrocution. Froth will not be there. Froth will not be there if it is a case of hydrocution. If it is a case of dry drowning, it's a case of dry drowning, you will not see froth. And do remember, if the person was unconscious at the time of falling into the water, again you will not find froth. Okay, so you can say easily like the froth will be found only in a conscious person in a case of wet drowning. Conscious wet drowning, you can see that. Otherwise, you don't see normally froth, right? Cadaveric spasm, presence of grass or weed, tightly clenched hand, definitely that is an antemortem phenomenon. I told you earlier, right? The first question itself, we discussed about cadaveric spasm. This is a typical antemortem finding. If they ask you if they give you 4 or 5 findings, and if they ask you which is the surest sign of antemortem drowning, you can easily choose cadaveric spasm. That is a surest sign of antemortem drowning, because when compared to any other finding, this has to be the surest one. This is even more specific for antemortem phenomenon. So let us look at the internal findings now. When we look at the internal findings now, you can see emphysema aqueous, right? Emphysema aqueous is one important finding that you can see in a conscious person drowned in a water. Emphysema aqueous, conscious person drowned in water. So you'll have a lot of froth. Okay. When the unconscious person drowned in water, that is edema aqueousum, where froth will be very less, edema will be more. Presence of sand particles in the airway, particularly when it is there in the lower airway, it is even more suggestive of antemortem drowning. When the water goes inside, the mud particles also goes inside. When the person is actively respiring, actively struggling, right, it will go deeper into the lower airway. Presence of water in the stomach or small intestine, again it is suggestive of antemortem drowning. You can see if it is muddy water, see, you can say that sir, the person could have drunk the water before falling into the water, he could have had some drinking water, fine. So that is why if there is any water which is even more muddy and that is present in the gastric cavity, definitely the person was alive at the time of drowning, he has fallen into muddy water and it has gone inside, you can say that is more suggestive. Fault of hemorrhages, hemorrhages that is due to rupture of alveolar walls, alveolar capillaries, when the person is actively struggling to have breathing. And you can see temporal bone hemorrhages and water in the middle ear, that is again suggestive of antemortem drowning. These are all the findings that we can see during autopsy. But if you want to do some test and find out whether the person was alive or not, the one common test that we can do is that is your diatom test. You might have heard about another test that is called Gettler's test. Gettler's test is something that you can differentiate between freshwater drowning and saltwater drowning. But diatom test will help us to find out whether the person was having active circulation or not. In other words, the person was alive or not. Right? If the person was alive, remember, when a person has fallen into water, water enters into the lung. Along with the water, diatom also enters into the lung. Diatom is nothing but algae. Fine. When the person was alive, he is having intact circulation, blood is flowing throughout the body. Along with the blood, diatom also is circulating throughout the body. So if you are able to find out, if you are able to demonstrate diatoms in a bone marrow, or if you are able to find out in other visceral organs like brain, spleen and all, that means he was having intact circulation. If the person was having intact circulation, you can easily say the person was alive at the time of drowning. You can say that is antemortem drowning. Fine. So these are all the findings that are suggestive of antemortem drowning. Fine. So you can see that watchwoman's hand, that was the finding which is non-specific and that can be easily ruled out from the question. Fine. Moving on to another question. So this is a very, very common topic. If you have been observing the INI-CET questions of last 3-4 years, you must be able to see one question in every session with regard to the medico-legal examination of rape victim survivor. Right? So this is one basic concept that every registered medical practitioner has to know. Fine. So let us talk about that. A 12-year-old girl is brought by the lady police sub-inspector with alleged history of sexual violence 2 days back. She was accompanied by a mother, and the registered medical practitioner should do which of the following as a next step. So they're not asking what all you will do. They're asking what is your next step. That means you have to choose one option. What are the key points that we can derive from this question? Remember, she is a 12-year-old girl. 12-year, that is again important. Fine. She can give consent for medical examination, but she cannot give consent for genital examination or any other advanced investigations. Radiological examination, she cannot give consent. And another point that you have to take from the question is, it is a case of sexual violence. They have not mentioned about any penetrative or non-penetrative, they are not given that. So just as a case of sexual violence. Another question is, she was accompanied by the guardian, that is mother. So these are the three keywords that we can get from this question. Look at the options. Do you have to preserve clothing? Take consent for genital examination. That is another important point that we have to see with the age. Take a detailed history, documentation of injuries and the examination findings. So these are the options that were given. Remember, she is a 12-year-old girl. That means it comes under POCSO Act. Right? POCSO Act. She is a child. As per POCSO Act, a child is a person less than 18 years of age. Fine. So when such a case is brought for examination, what are things we have to do? What you can do is first ask detailed history. Right. Then you have to get consent. You need to get informed consent. If the person is not giving consent, you have to get informed refusal. Get it signed. Informed refusal. Okay. If you are getting consent, remember you have to get consent. Minimum age for consent for general physical examination is 12 years. If you're going to do genital examination or any other radiological investigative procedures, then you have to have 18 years as the minimum age. If you're not able to get valid consent from the particular victim, you can get the consent from the guardian. that we can do. Fine. And the third thing is, and one more important point that you have to keep in mind, do you have to get the consent mandatorily from the person? Remember, this informed consent is mandatory. That is again very, very important, right? Consent from the assault survivor is very, very important. That is mandatory. Fine. And after getting consent, you can get the examination done, right? Examination can be done, right? While you do the examination itself, you can collect and preserve the evidences. Collection and preservation of evidences. And if there is any injuries or anything, you have to give treatment to the victim, and you also have to do police intimation. These are the normal things that are included in the particular process. Okay, so these are the important steps that are included in the process as such. Fine. So everything starts with history. So when you answer this question, your first answer should be about taking a detailed history, right? You need to know what case it is, right? So you take the detailed history. From then on, you can continue with the other things. So the next step would be taking detailed history. You have to preserve the clothing, but for that you have to start the examination, right? So this cannot be the ideal answer. You can't take consent for genital examination. Documentation of injuries and examination findings can happen only when you start the examination. So everything else can be ruled out. The logical answer would be your taking detailed history. And now with regard to this examination of sexual assault survivor, remember the two important sections that are relevant for this discussion is 164A CRPC. That is one important relevant section here. Another important relevant section is section 27 of POCSO Act. Section 27 of POCSO Act. These are the two sections that we have to keep in mind with regard to medico legal examination of the victim, right? Both says the same thing only, because see, if you're talking about consent, consent is mandatory. You cannot get the examination done without the consent of the person. That is very important. And as per the POCSO Act, if you are examining a female victim, right, in case of a female child, ideally she has to be examined by the female registered practitioner. And when we are doing examination under POCSO Act, remember, we need to have a parent or the guardian, right? We can do the examination in the presence of the parent or the guardian. That is another point that we have to keep in mind. These are the two sections which are relevant to this examination. So this is another question of INI-CET only, again based on the same topic. A 13-year-old girl, a history of sexual abuse by 20-year-old boy 6 hours ago, presented to ER with her mother. She refused for consent for medical legal examination. Police is not accompanying. What is the next thing that we have to do? Next thing, do you have to collect swab or examine by force? You cannot examine by force. That is not possible. You cannot collect swab because she has refused consent for medical legal examination. You have to take consent for refusal. That's what I told you. You have to take consent for refusal. You can treat her for STD or pregnancy because she refused only for the medical legal examination, not for the medical treatment. You have to obviously inform the police, right? If you have to choose one option, you can choose take consent or inform refusal. Fine. One thing that you have to know is you cannot examine by force. A 5-year-old boy went to a temple in a village with his grandmother. He was crying inconsolably on the way back. He was taken to the emergency department within 3 hours. He had altered sensorium, cold, clammy extremities, increased salivation, excessive sweating. On examination, he was pale, he had priapism, BP was higher, heart rate was higher, respiratory rate 36 per minute, and saturation is 96%. Which of the following would you suggest in the management? See, this is a typical case of scorpion sting. This is a typical case of scorpion sting. When a 5-year-old boy had got crying inconsolably, right, and presenting with features of cold, clammy extremities, excessive sweating, salivation. So all these features will tell you it is a case of scorpion sting. The priapism, this is again, see, normally in case of envenomation, there are two envenomation that can cause priapism. One is due to snake bite, another one is scorpion sting. Right, snake bite priapism can happen, but that is a little rarer than when you compared with priapism associated with scorpion sting. Right, and in this there is no mention about fang mark, and there is no other case of neuroparalysis or nothing. So this cannot be a case of snake bite. So we have to obviously go to the, we have to narrow our diagnosis to scorpion sting. So we know it's a case of scorpion sting. So what should be the next line in the management, the obvious option would be Prasocin. Let us have a detailed discussion of scorpion sting. This is important because this is the second time we have gotten this question. We need to have a detailed discussion on that. See, scorpion sting, you can see scorpion. Most of the scorpion stings are basically accidental, and it is not usually fatal. Most of the scorpion stings are usually benign. Mostly it will be a dry sting where only pain will be the most important feature. Other complications, systemic complications, do not happen, except in case of children. It can cause significant fatality. The mortality can be more in children, right? And most of the bites will be nocturnal because they are nocturnal feeders. Scorpions is nocturnal feeders, so scorpion sting cases will be usually nocturnal, and it is usually affecting the peripheries, extremities, right? The fingers, toes, like that. See, with regard to India, there are two important scorpions. One is Indian red scorpion. Another one is black scorpion, black one, right? This Indian red scorpion, that is belonging to the family Mesobuthus, right? Indian red scorpion, that is Mesobuthus tamulus, and black one is Palmneus. That is not so important, but Indian red scorpion is very important. That is very toxic. When you look at the scorpion venom, see, the scorpion venom, it is so dangerous than the snake venom. If you see the quality of the venom of scorpion, it is more dangerous than snake venom as such, but the quantity that is injected is very less. That's why fatality is very less. It has got, qualitatively, it is very similar to all the enzyme that is present in the snake venom as well. It has got a neurotoxic feature. It has also got hemotoxic feature. It is very important. How does it act? See, normally this venom of the scorpion, but particularly the Indian red scorpion, it stimulates the voltage sensitive sodium channels. And it also inhibits calcium dependent potassium channels. When it is stimulating the voltage sensitive sodium channels and it is inhibiting the calcium sensitive potassium channels, it causes uncontrolled release of catecholamines into the circulation. The scorpion venom has got lot of toxins. We have got histamine, we have got serotonin, we have got substance P, we have got alpha toxin, beta toxin, we have got kallikrein. We have lot of enzymes are there. Let us look at the few important things. The substance P and the serotonin, these things can produce severe excruciating pain. It is not just pain, it is excruciating pain. You can see that is mentioned in the question as such. The person was crying inconsolably, excruciating pain. And this is where we can see something called tap sign. When you tap the particular side, you can see the person will be having severe pain. Tap sign, right? Remember, so this is the pain that will be very excruciating. Sometimes if only pain will be there, no other signs of systemic envenomation, you call it as dry sting. Okay, dry, you can say dry bite or dry sting, doesn't matter, right? If when only pain is there, no other systemic toxicity is there. Another important toxin that we have to know is we have got alpha toxin, we have also got beta toxin, right? Basically, they have got actions on the adrenergic receptors. Significantly, it affects the alpha, right? It causes stimulation of alpha receptors. That is very significant. And as I told you, it causes uncontrolled release of catecholamines into the circulation. We call this as autonomic storm. When there is autonomic storm, we have got what is called as cholinergic excess. We have also got adrenergic excess. We have got stimulation of cholinergic system. We have got stimulation of adrenergic system. Cholinergic excess, and we have also got adrenergic excess, right? So this is a concept that we have to add. When it is cholinergic excess, the person will be having salivation, excessive secretions, right? It is not only salivation, the person will also be having increased secretions in the airway. That can even cause respiratory failure as well, right? Salivation, sweating, excessive sweating, vomiting, abdominal pain. The person will be having priapism. The person will also be having bradycardia, decreased heart rate, bradycardia, hypotension. All this is due to cholinergic stimulation. When it is adrenergic stimulation, do remember the patient will be, I told you that it is significantly affecting the adrenergic alpha receptors. So there are two important sites which are affected by this venom. Two important sites. What is that? One is your blood vessel, another one is the heart. So when the blood vessels are stimulated, what happens is the person will be having vasoconstriction, hypertension. Hypertension. When the heart is affected, the person will be having excessive heart rate, tachycardia, uncontrolled heart rate. You can even see that the heart rate is around 152 per minute, right? Excessive tachycardia will be there. So when the person is having hypertension, excessive heart rate, tachycardia, what happens is the person will be having myocardial dysfunction. The EF will keep on decreasing, myocardial dysfunction. When there is myocardial dysfunction, the person can develop pulmonary edema. The person can develop pulmonary edema. The person can also develop hypotension. The person can develop cold, clammy extremities, cold extremities. The person can develop shock-like features, right? So all these features can be seen because of myocardial dysfunction. Apart from this, the person will have other complications like pancreatitis, acute pancreatitis features can be there. Sometimes patients can develop stroke, right? The person can develop hemiplegia. The person can develop encephalopathy. CNS features also noted. Sometimes the person can also develop a complication DAC. DAC is not seen only with the viper snake bite. It can also be seen with scorpion, but all these complications are very rare, right? Fine. We just have to know the other features, atypical presentation as well. So I told you that it causes cholinergic excess. It also causes adrenergic excess, right? Cholinergic excess, increased secretions, and adrenergic excess, the person will be having hypertension, tachycardia, and you've got myocardial dysfunction resulting in shock-like feature or the pulmonary edema. Let us look at the manifest treatment management part. You can see that I have just listed out all the probable clinical features, and based on the clinical features we can discuss. If the person is having excruciating pain, what we can do is we can apply local ice pack, local application of ice pack, or you can give lignocaine infiltration, local infiltration of lignocaine, right? Or you can also give NSAIDs, right? Do prefer NSAIDs rather than using opioids. Better to avoid opioids. NSAIDs have to be preferred. Local infiltration of lignocaine, local application of ice packs, and we can also use NSAIDs for the pain relief, right? Now coming to the systemic envenomation. When the person is having other remaining features, you can call it systemic envenomation. One of the gold standard drug that we can use here is the selective alpha blocker, that is prazosin, right? So that is very, very important. You can say that is the gold standard drug for controlling all the adrenergic excess, autonomic storm. Another important drug that we can use is, you can see that if it is available, we can use ASV, right? It is not anti-snake venom, it is anti-scorpion venom, right? We have got monovalent anti-scorpion venom that is available for Indian red scorpion. That will be neutralizing the venom of Indian red scorpion. But this can be used only when you classically know this the type of scorpion, right? If you know that is Indian red scorpion, we can use this anti-scorpion venom, right? We can't use indiscriminately, because again the source of anti-scorpion venom is from horse serum. Again it may cause allergic reactions as well. So we have to be very cautiously be using this anti-scorpion venom, but we can use prazosin. That will be very, very effective. If the person has got tachycardia, if the person has got hypertension, what we can do is we can give sodium nitroprusside, or we can also give NTG, right? Nitroglycerin, right? Or if the person has got pulmonary edema, we can use diuretics, right? Based on the case, and we have to keep the BP also in consideration, and we can start using diuretics for pulmonary edema. And if the person is suffering from hypotension, shock-like features, we can use dobutamine, right? Or dopamine, right? So these are the treatment options that we have got for different kind of features. And the one, as I told you, the best drug that we have gotten for the scorpion management is prazosin. So that will be the best option available. So this question can be answered even if you don't know this clinical features in detail about scar piercing, doesn't matter. You can just look at the options. You can easily exclude, right? So this is not a case of snake bite. You can easily exclude the option snake bite. Of course, this is a case of other envenomation, that is prazosin, right? Adrenaline, definitely not, because already the person is having adrenergic excess, right? Okay. So during the examination of drunkenness, the patient smells of alcohol, the conjunctiva appears red. During examination, the motor coordination is normal and he can walk in a straight line. His gait is very much normal. He can talk without any problem. He's talking normally, right? Which of the following is true? As he has consumed alcohol, but he's not under the influence of alcohol. He has consumed alcohol, but he's under the influence of alcohol, and he has not consumed alcohol, right? Fine. So what is the best option that we have got? If you look at this question as such, there are three important points that we can derive from this again. One is the smell of alcohol that is present, right? Conjunctiva, that is red, so that is so non-specific. You cannot exclude that. You cannot include that. During examination, the motor coordination appears to be normal. Finger notice, finger notice, all your tests for motor coordination, that is absolutely normal. He is able to walk in a straight line. That is again very important point. And he can talk properly. There is no slurring of speech. All this will tell you the person has consumed alcohol, but is not under influence, right? Let us look at the different combinations, right? You can see that there are two things that are noted in this. One is the smell of alcohol. Another one, whether the person muscle coordination is normal or not. We have to see the muscle coordination, that is normal or not. Fine. If the smell of alcohol is present and the muscle coordination is normal. If the smell of alcohol is present but the muscle coordination is abnormal, right? If there is no smell of alcohol, muscle coordination is again normal. Fine. If there is no smell of alcohol, again the muscle in coordination will be abnormal. There is muscle in coordination, there is abnormal muscle coordination. These are the different combinations that we can get. If the person is having, let us see the first combination. If the person is having smell of alcohol present and the muscle coordination happens to be normal, we can say the person has consumed alcohol, but he is not under the influence, right? He's not, maybe he has consumed little amount of alcohol, or he is a chronic alcoholic, which he needs so much of alcohol to have effect, right? So he has consumed alcohol, but he's not under the influence. If the smell is present and the coordination is abnormal, we can say the person has consumed alcohol, but he is under the influence of alcohol. The person has consumed alcohol, he is under the influence of alcohol. There is no smell, means he has not consumed alcohol itself, right? And the coordination is normal, no problem. There is no smell of alcohol, but there is muscle incoordination. This maybe the person is suffering from some other cerebellar disorders, right? He is suffering from some other nervous disorders which is causing muscle incoordination. Fine. So remember that if the person has, this is the person has consumed alcohol and he is not under the influence, no influence, no influence. Here the person has consumed alcohol, is under the influence. The person has not consumed alcohol itself, right? Here the person is suffering from some cerebellar disorders. So these are the different permutation combinations that will be available from this examination, and we have to issue the certificate based on the findings available. And remember, the smell of alcohol itself is not confirmatory that he has consumed alcohol. And he might have taken alcohol, he would have gargled the mouth and he could have spit it, still you will have some amount of smell of alcohol. But if you want to confirm the smell of, confirm whether he has consumed alcohol or not, right, what we can do is we can do blood test, right? You can do blood analysis of the detection of alcohol, right? Whether the alcohol is present in the blood or not. You can also you take urine sample and you can analyze the presence of alcohol. All this will tell you alcohol is being consumed, right? So in this, the best option is he has consumed alcohol, but he is not under influence. Identify the following image. The image was given, there was some vesication, the blisters was noted in the chest and trunk, and the most important clinical clinching point is like you will have blisters with surrounding hyperemia, right? Reddish erythema was noted, right? Whether it is a blister due to barbiturate poisoning, whether it's a blister due to antemortem burns, whether it's a blister due to chemical burn, or it is due to pemphigus vulgaris. It is not pemphigus vulgaris, because even though pemphigus vulgaris is a bullous disorder, here the lesions are only specified in the chest and trunk. There is no mention about the oral or any mucosal lesions, right? That can be ruled out. It is not barbiturate blister. That is because barbiturate is basically dermonecrotic, and that is the reason why it produces blister. But the point is that this kind of blister is normally seen in the frictional areas, interdigital cleft, in the genital region. These are the places where we normally get this barbiturate blister. So it is not in the chest and trunk. So that is, again, we can rule out. This is not the answer. Whether it is the blister is due to ante-mortem burns or whether the blister is due to chemical burn. So these are the two options left out. When you see chemical burn, blisters are usually very, very rare in a case of chemical burn. So that can also be ruled out. Blisters are seen with chemical burns. Yes, it is seen, but it is very, very rare. If you look at the chemical burn, normally what happens, the skin will be destroyed. You can see ulcerated skin, ulceration will be there. You will find the typical Eschar formation that will be there. Vesicles will be there. Vesicles are but so rare. Vesicles are rare, right? And no charring. Charring will not be found, right? So when you look at the blister, which is so typical with the surrounding hyperemia, you can easily choose that it is ante-mortem burns, right? If one of the option was given as blister due to post-mortem burns, again you can easily find out that as we discussed earlier in the first question, if it is reddish erythematous base and the erythematous area around it, the content is inflammatory fluid, you can easily choose that is ante-mortem burns blister. If the content is a gas and the base happens to be pale, that is post-mortem blister. Maybe like next time they can give you that option and they'll try to ask you to find out which is the best answer, right? So in this question, the ante-mortem burns is the best option that we have got, right? In death due to firearm injury, the entry wound shows only the abrasion collar, right? Only the abrasion collar, and the range of firearm is dash. Remember here they did not mention whether it is rifle wound or it is shotgun, but they did mention about abrasion collar. So definitely it has to be a rifle firearm. So now we can understand that it is a rifle firearm. So we'll have to discuss the different appearance of wound at different ranges in a rifle firearm. Remember, whenever we have a firearm and when we shoot, there are few discharges coming out, and these are the 4 discharges that is coming out. One is the flame, another one is the smoke, another one is a partially burned gunpowder or unburned gunpowder, and the last one is a bullet. That is the most important component coming out, right? Each of the discharges will have specific effect on the wound. Remember, the burns is due to fire, the singeing of hair is due to fire, right? Smoke produces blackening. Unburned gunpowder gets deposited in the skin layers. You call it as tattooing, also called as peppering. Right? Bullet produces 3 important effects. One is the punctured hole, another one is the grease collar, another one is the abrasion collar. Remember, sometimes grease collar is also called as bullet wipe. That was again asked as one of your AIIMS exam question, bullet wipe, right? So these are the effects that are produced by the discharges: fire, smoke, gunpowder, and the bullet. Now everything will stop at a different range. Not everything will go to an equal distance, right? Everything will stop at a different range. Everything will stop at a certain specific distance. Based on that, you can find out the range. Remember, there are 5 ranges in this particular thing. So we can see that there are 5 ranges in this. We can have contact shot when the gun is kept in tight contact with the skin. We have got close shot. We have got near shot. We have got intermediate. We've also got distant. All depends on the distance, right? You can also see that contact shot is something when a gun is kept in contact with the skin. Remember, you can see that here is the flame stops. When the victim stands in within the range of flame, you call it as close shot. When the person is standing outside the flame but inside the smoke, you call it as near shot. When the person stands outside the smoke but inside the gunpowder, you call it as intermediate shot. When the person stands outside the gunpowder, right, you call it a distant shot, right? So you can see at different ranges what are the discharges available. Remember, if it's a distant shot, only the bullet is available. You can see the bullet hole with 2 collars, right? In a case of intermediate shot, you can see that the bullet is also available, gunpowder is also available. You can see tattooing is also there. Bullet hole with 2 collars will be available, right? If it is near shot, you can see burning will not be there, blackening will be there, tattooing will be there, bullet hole with 2 collars will be there. If it is a close shot, you will see all the discharges, right? Burning will be there, blackening will be there, tattooing will be there, and the bullet hole with 2 collars will be there. Everything will be available. That is a closed shop, right? And in the question, remember what they have asked is, they have asked about the wound is showing only abrasion collar, right? Right. Ideally, they should have given grease collar as well. Fine, right? So if it is having only bullet and the abrasion collar and the grease collar, remember it has to be a distant shot, right? So that is quite easy to identify. So here is where you can see a contact shot, wherein you can see a stellate wound. Inside the track of the wound, we can see all the effects. In this wound, you can see the bullet hole, you can see the tattooing, you can also see the blackening effect as well. Here you can see the bullet hole, only the gunpowder tattooing is available. Here only the bullet hole with the abrasion collar is available, right? So these are the different appearances of the wound that you can appreciate. Formication or Mignon system, this is again a very easy question, very old question, right? This is seen with cocaine. That's a very easy question, right? You can see that chronic cocaine abuse, normally cocaine is abused by snorting, right? So if a person is got, due to repeated chronic snorting, the person might be having peripheral gangrene. The person may be having peripheral gangrene. That is because of the persistent vasoconstriction of cocaine. And the person may also be showing septal ulceration. Sometimes perforation may also be available, right? Or if there is any black staining of the tongue. Remember, if these 3 features are available in a person, right, you can easily find out that the person is addicted to cocaine for a long time. It's a sign of triad of chronic cocaine abuse. So when a person is chronically abusing cocaine, see, cocaine is usually sympathomimetic, right? So it causes CNS stimulation. When a person is chronically abusing cocaine, what we can see is, we can find out cocaine-induced psychosis, right? Cocaine-induced psychosis. In this cocaine-induced psychosis, you can expect the presence of delirium. We call it as excited delirium, right? And datura, we get muttering delirium. Here we get excited delirium. The person will also be showing delusions, and you will also be able to find out hallucinations in this person. And the type of hallucination that you can appreciate is tactile hallucination. Person will feel multiple insects are crawling on the skin, right? You'll keep on scratching. You call it as formication, also called as Mignon symptom, otherwise called as cocaine bugs, right? Okay, so insects, that's a formication. So very easy question. So this is the source of cocaine, the leaves of Erythroxylum coca. This was asked in one of your previous AIMS exam. Okay, leaves of Erythroxylum coca, and this is cocaine powder, right? Snorting. This is for snorting. This is tactile hallucination, cocaine bugs. Which of the following is not a part of right slogan? RIGHT. Right? RIGHT, snake bite management. Usually you get questions on the identification of snake and snake bite features, envenomation, but this time we have gotten question on the management. You can see RIGHT, the first aid slogan. R for reassurance. Psychiatric reassurance is very, very important, because the person will be totally having anxiety, palpitation, everything. Reassurance is very, very important. Reassurance, right? And you can see that immobilization, pressure immobilization, fine. And you can apply cloth or bandage, fine. We call it a Sutherland's technique, fine. And go to hospital, get to hospital immediately, right? That is immediately, not after 2 or 3 days. Tell the symptoms to doctor. Systemic signs of envenomation to doctor, right? So that is a first aid approach. When a person has come to the hospital and you are the doctor working in the hospital, you got a patient of snake bite, how will you manage? The first thing is, right, what you can give, don't give anything. What you have to do is just observe the patient. You keep the patient under clinical observation, because most of the patients who have come with history of snake bite may not be showing any symptoms at all, may not be having any signs of envenomation. Maybe it's a non-venomous snake, or maybe it's a case of dry bite. Only if the person is showing signs of envenomation, then we can give ASV, that is anti-snake venom, which is polyvalent anti-snake venom, which is effective. Polyvalent means multiple snakes. It will neutralize the venom of big 4 snakes, right? Common cobra crate, Russell's viper, and saw-scale viper. What is the dose of this anti-snake venom? Remember, it is 10 vials anti-snake venom, IV, that has to be given. No need of any dose adjustment according to the age and sex of the person. Just give 10 vials IV, that should be fine. Okay, ASV. And it has to be given as early as possible. And if the person has come with neuroparalysis, we can also give IV neostigmine that will reverse the neuroparalysis in a case of cobra bite, right? Because the curare mimetic toxin present in cobra venom, it will be postsynaptic action, so it will be having postsynaptic action. So these neostigmine will be reversing the neuroparalysis of cobra bite. Fine. So other findings, like whatever the patient is having other complications, like if the patient needs wound debridement, we can give wound debridement. If the patient has developed DIC, we have to treat accordingly. Or any other patient, any other complication the patient develops, renal failure or something, we have to treat accordingly. That is supportive measures. But the one single most important treatment that we can give in case of envenomation, that is ASV, polyvalent anti-snake venom, right? So remember that. A 29-year-old female is brought to ER by the police due to being found unresponsive in the park. At the scene of crime, you can see empty syringe was identified. Respiration was so less, 6 per minute. Physical examination significant for depressed mental status. Bilateral tract marks, meiotic pupils. What is the antidote? This question is so simple, and this wasn't one question which have been frequently asked in the examination, right? They give you, it's a case of substance abuse. Patient has come with all these features. What is the treatment? They give you, it's a case of drug addict. Patient has come with these features. What is the treatment, right? And again, this time they have given you the clue. Patient has, you can see the empty syringe in the scene of crime. You can see bilateral track marks were there. That is IV. That means that person is basically an IV drug addict. Now coming to you with CNS depression, respiratory depression, respiratory rate is so less, respiratory depression, and a meiotic pupil. When you see these three features, triad, CNS depression, respiratory depression, and meiotic pupil in the background of IV drug addict, you can easily find out that is basically opioid abuse, that is morphine abuse. The antidote that is available is naloxone sodium. You can see the naloxone sodium. Naloxone sodium is a centrally acting pure antagonist of this receptor. So you can give naloxone sodium. That is the best option that we have got. Usually we get questions on the morphine, right? Like this, they'll give you the triad of morphine poisoning and they'll ask you what is the antidote that is available, right? You can easily choose that is naloxone sodium. This is level 1 difficulty, very frequently repeated. This is the poppy capsule that you can see. When you cut the capsule of the poppy, you get the milky juice. You wait for some time, that gets dried up. You will get the brown exudate. That brown exudate is the crude opium. We also call it as AFM, from which we get all opioids, right? That is AFM. When you cut the capsule, inside the capsule you get seeds. That is not toxic. So this is actually the crude opium, the dried form of the exudate, that is crude opium. Fine. So this is the poppy capsule. And I told you the treatment option available for morphine poisoning, we can give naloxone sodium. But one point that we have to keep in mind, that naloxone sodium has got very short half-life, maybe 2 to 3 hours. So the risk of rebound toxicity is very high, right? The risk of rebound toxicity is very high. So if the patient may be showing clinical improvement, we can't discharge the patient, right? Again, there may be a risk of rebound toxicity. Patient may go home, the patient may go outside the hospital, again you can worsen. The doctor will be charged for medical negligence, so we have to keep that in mind. So maybe a continuous infusion is needed or a repeated doses may be needed. So there is naloxone sodium, right? So that is marking the end of the questions asked in INI-CET May 2023 session. I hope you got the concepts clear, right? So keep working hard, learn well, achieve well, all the best. Thank you so much.